My name is Zaalouk. I'm a cardiology demonstrator in Alexandria University. I will present my case directly. Our patient is a 58-year-old male. He is an office worker. He has a sedentary lifestyle. He is an ex-smoker with a high body mass index of 31 kilograms per meter squared. He presented to our clinic complaining from dyspnea. Functional capacity is about 3 to 4 METs and the NIHA class 2, together with easy fatigability and mild bilateral ankle swelling. The past medical history of the patient is a full-blown metabolic syndrome with type 2 diabetes mellitus and hypertension diagnosed more than a decade ago, together with dyslipidemia, chronic kidney disease, but actually, fortunately, did not suffer from any acute cardiovascular event. His drug history is extensive, and he claims to be compliant on all of these medications, a triple single-pill combination for hypertension, including an ACE inhibitor. We have metformin and glimepiride together with insulin for the diabetes mellitus. We have an atorvastatin 40 milligrams for the dyslipidemia, together with aspirin 81 milligrams and gastric protection in the form of PPI. Okay. Okay. Moving on to the clinical examination, he was vitally stable, but he suffered from an uncontrolled blood pressure. The blood pressure was 180 over 100 millimeter mercury. The heart rate was 70, and otherwise the examination was unremarkable except for mild bilateral ankle edema, as mentioned before, and reported by the patient himself. Here are the laboratory investigations done for the patient on an outpatient basis. We have an uncontrolled diabetes in the form of HbA1c of 8.2. The fasting blood sugar is 155 milligram per deciliter. We have also a high serum creatinine of 1.9 milligram per deciliter and a destabilized GFR, which dropped from 45 to 32 milliliter per minute per 1.73 meters squared. We have a borderline high potassium of 5.2 milligram per deciliter, millimole per liter. Also, the dyslipidemia profile is not good. The LDL is 102 milligram per deciliter, together with a triglyceride level of 220 milligram per deciliter, and this was a fasting triglyceride level. Also, we have a BNP of 185 picogram per milliliter, which is elevated. We performed an electrocardiogram and a transthoracic echocardiography for the patient. As part of the cardiology workup, the ECG revealed a normal sinus rhythm with LV strain pattern, with ST depressions and T-wave inversions in the lateral leads. And then we performed the transthoracic echo, which shows a preserved biventricular systolic function, normal LV chambers, but we have an increased LV wall thickness. The septum and the posterior wall were together 14 millimeters. We have a calcific posterior leaflet of the mitral valve and a dilated left atrium with a bit redundant interatrial septum. There are no regional wall motion abnormalities across the LV in all views. Here's the parasternal long axis view, showing there is a trace or mild aortic regurgitation, and shows the calcification which is present on the posterior leaflet of the mitral valve. And here we have the mild to moderate mitral regurgitation evident in the apical two-chamber view. And we have also a dilated inferior vena cava with reduced collapsibility index. We measured the ejection fraction by biplane method, and we got a 57%, although by eyeballing it appeared a bit more than that, but the calculation revealed a 57% ejection fraction. We also have a grade 2 diastolic dysfunction with elevated filling pressures. The end diastolic pressure was 17 millimeter of mercury. And we have a dilated left atrium, as was previously seen in the apical views, and the left atrial volume index was 42.5, which is a moderate elevation. And we have also the pulmonary artery systolic pressure is 45, evident by the tricuspid regurgitation and the dilated IVC. So to summarize, our patient is actually a full-blown metabolic syndrome presenting with symptoms suggestive of heart failure. We have uncontrolled hypertension. We have uncontrolled lipid profile together with uncontrolled diabetes profile. We have a destabilized GFR and renal functions, and we have a high BMI. Thank you so much.